Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence based updates. On this episode, Associate Editor and Clinical Pharmacist Sara Klockars breaks down what pharmacy teams need to know about MASLD and MASH, including the latest evidence on Semaglutide and Resmetirom, along with key opportunities to support patients throughout their treatment journey, in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. With that, let's get started.
And we're talking about this since injectable semaglutide, Wegovy, is the first GLP-1 agonist approved for certain patients with MASH. And before we dig in more, let's just review the spectrum of metabolic dysfunction-associated steatotic liver disease. This will come into play when we talk about treatment options. And this is when there's excess fat in the liver in a person with at least one metabolic risk factor, such as insulin resistance or diabetes, high cholesterol, obesity, and that can cause fat creation in the liver or that steatotic liver disease or fatty liver disease. And then if it's left untreated, the disease progresses. And then we have metabolic dysfunction associated steatohepatitis or MASH. And this is when the fat buildup leads to inflammation and damage to the liver cells. And then it can progress to fibrosis, or this is when scar tissue starts to replace that normal tissue in the liver and eventually can progress to cirrhosis when scarring is extensive, severe, and it usually can't be reversed. Or it can also lead to liver cancer. So you can see why it's important to try to find it early and to treat this early. And we're hearing more about metabolic dysfunction associated steatotic liver disease because it's a leading cause of chronic liver disease. In fact, about 1 in 4 adults in the US have MASLD, and about 15 million adults in the US have MASH. So it's important to note that the prevalence is rising. And this increase goes hand in hand with increases in the metabolic risk factor. So many may not know they have this since patients with MASH usually do not have symptoms. And we rely on screening when patients have these risk factors. So diabetes and obesity seem to have the most impact on the history of MASLD and progression to MASH. Some other risk factors include high cholesterol, high blood pressure, smoking, postmenopausal women, and males over age 50 years. When it comes to managing patients with MASLD, lifestyle changes and controlling comorbidities are key for all patients. So, weight loss is the most important treatment. Losing over 5% of body weight reduces liver fat. Losing over 10% can lead to MASH resolution and reducing that liver fibrosis or scarring. So, those weight loss strategies, healthy eating, physical activity, those are the cornerstone of managing MASLD. And then beyond weight loss, we want to advise limiting alcohol since alcohol can worsen liver damage. Advise smoking cessation since smoking is a risk factor for MASLD. And also, because of those metabolic conditions, the diabetes, high cholesterol, high blood pressure go hand in hand with fatty liver disease, it's important to optimize meds for these conditions. So, one example, we want to continue to recommend statins to reduce cardiovascular risk in patients with high cholesterol and MASLD. But you might be wondering if statins are safe to use in patients with this type of metabolic liver disease, and they are. In fact, some data suggests potential benefits of statin therapy in patients with stable liver disease, including MASLD. So, optimizing the treatment of these comorbidities is key before considering MASH specific medications. And as I mentioned earlier, we now have injectable semaglutide or Wegovy, and we also have resmetirom or Resdifra as these two FDA-approved options to reduce that liver fat and inflammation when lifestyle changes and weight reduction aren't enough. We don't have good evidence yet that these meds reduce risk of cirrhosis or liver transplant yet. We may see one of these meds used for non-cirrhotic MASH with moderate to advanced liver fibrosis, stage F2 to F3 fibrosis, along with a healthy diet and exercise. So, what does that mean? So, jumping back to the progression of MASLD, these meds are for a more advanced form of MASH when patients have scar tissue or fibrosis, but yet not for cirrhosis. So, this is usually diagnosed by specialists with the use of different risk calculators, special ultrasounds, imagings of the liver, and in some cases, a liver biopsy to look more closely at those liver cells. Liver function tests can be used as a marker, but not for diagnosis. So, for example, liver function tests can be normal in patients with MASH. So, honing in a bit more, there are different stages of fibrosis. So, F0 is no fibrosis, all the way up to F4, which is cirrhosis and extensive scarring. And these stages come into play since these meds are specifically for stage F2 or F3. And this will be important if you handle prior auths. So, if a MASH specific med is needed, expect most patients to get injectable semaglutide, especially if the patient has another indication for a GLP-1 agonist, such as obesity. And when injectable semaglutide is used for MASH, patients will start at that dose of 0.25 milligrams once weekly, increase monthly as tolerated to that target dose of 2.4 milligrams once weekly. And just a quick note that the injectable Wegovy HD or high dose of 7.2 milligrams that's been approved is for weight reduction in adults. So when you get a prescription for injectable semaglutide, enter directions correctly, double checking those strengths and SIGs when calculating day supply and filling prescriptions. And also ask about the indication for these products just to double check you have the right med, since there's also injectable semaglutide for diabetes. Don't automatically substitute oral Wegovy or injectable Wegovy. They're not considered equivalent. And other semaglutide dosage forms aren't approved for MASH. When it comes to efficacy, injectable semaglutide once a week for 72 weeks with diet and exercise leads to MASH resolution, which was defined as minimal to no liver inflammation or cell injury in about 1 of 4 patients treated versus placebo. Plus, about 1 in 7 patients have fibrosis improvement. And as we know with GLP-1 agonists, GI side effects are common, so that nausea, vomiting, diarrhea, and these can usually improve over time. There are some strategies we can share with our patients to set them up for success, such as reinforcing the need to start at that low dose, slowly increase the dose. We can slow the titration if side effects are too severe. And as pharmacists, we can counsel patients on adjusting their meals. So, for example, advise eating smaller meals more slowly and to stop eating before they're full. And it's also a good reminder that these meds, along with rapid weight loss, may lead to gallbladder problems, so patients should report severe stomach pain right away. And then moving along, we also have resmetirom, which activates thyroid hormone receptor beta, which is a major form of thyroid hormone receptor in the liver. And by doing this, it's thought to increase the metabolism or breakdown of that liver fat and then reduce fatty acid and triglyceride formation and buildup in the liver. Resmetirom is dosed based on actual body weight, usually 80 or 100 milligrams once daily. There's also a 60 milligram dose that may be needed for dose adjustments due to drug interactions. And then it's a specialty med available via limited distribution and costs about $4,200 a month. So expect prior auths if you dispense this. And when it comes to efficacy, oral resmetirom daily for 12 months with diet and exercise leads to MASH resolution in about 1 of 6 patients treated versus placebo. Plus, about 1 in 10 patients have fibrosis improvement. And there are some other things to consider for patients using resmetirom. It has many interactions, so pay close attention to the interaction warnings if you dispense this. For example, as I mentioned earlier, we want to treat comorbidities, which often include high cholesterol, so patients are often on statins. But resmetirom can increase concentrations of some statins in the blood. So if a patient's getting a new prescription for resmetirom, we may need to recommend a lower statin dose. For patients taking resmetirom, we'd want to limit rosuvastatin or simvastatin to a max of 20 milligrams a day, and pravastatin or atorvastatin to a max of 40 milligrams per day. We also want to caution about common side effects: diarrhea, nausea, itching. We also think of resmetirom as helping liver function in patients with MASH, but it can also cause liver injury. So patients will need baseline and follow-up liver function monitoring, which is likely typical for patients with MASH, and then tell patients to promptly report severe GI pain, which can be a red flag for rare gallbladder problems that can happen with resmetirom as well. But before we move on to other meds, I just want to note that resmetirom hasn't been directly compared to injectable semaglutide. We also don't have good evidence on using these two approved meds in combination for MASH yet. It's intriguing since these two meds have very different mechanisms of action. Plus, some patients in the phase 3 resmetirom trials were on GLP-1 agonists, and the secondary analysis showed similar results in all of these patients. So the patients using both didn't fare any better. In addition, the combination may not be covered by some payers, but the landscape in MASH treatment is changing rapidly. And I want to touch on a few other options you may see. Oral pioglitazone or Actos may lead to MASH resolution in about 1 of 4 patients and may slow fibrosis progression. Studies are small, but have consistently shown improvement. In fact, the American Diabetes Association recommends pioglitazone either alone or with a GLP-1 receptor agonist for patients with type 2 diabetes and MASH. But keep in mind the risks of pioglitazone: modest weight gain, fluid retention, potential heart failure exacerbations. So just keep that in mind. And then vitamin E has gotten some buzz over the years, but there's limited evidence it may reduce liver fat in patients without diabetes. Plus, some evidence suggests vitamin E is linked with bleeding, prostate cancer, stroke, and other risks. So, vitamin E has really fallen out of favor with these newer options. And then we have many other promising meds, including other GLP-1 agonists. For instance, one phase 2 trial suggests tirzepatide 15 milligrams a week leads to MASH resolution in about 1 of every 2 patients treated for 52 weeks compared to placebo. Many other GLP-1 agonists are in the pipeline that appear to be very effective. Plus, there's some evidence to suggest the SGLT2 inhibitors may reduce liver fat in patients with type 2 diabetes. In addition, many meds with new mechanisms, such as a fibroblast growth factor 21 analogs, are in phase 3 trials, so stay tuned. And let's chat quickly before we wrap up about what else we can do in our pharmacies, since so many patients we see every day have metabolic risk factors for MASH. In addition to reinforcing those lifestyle changes, we can help keep med lists current, asking about meds from other pharmacies or delivered to their house. This can also help us see if patients are on statins or blood pressure medicines, refilling them regularly, and we can help try to optimize the treatment of those risky comorbidities. And since we have so many GLP-1 agonists and they're used for many different indications, we definitely need to stay alert for duplicate therapies. For example, a patient may receive semaglutide from a liver specialist for MASH, but maybe they're on tirzepatide from their primary care clinician for diabetes. So we would want to alert the pharmacist to this combination. And we can also continue to help with prior auths for these medications. For instance, semaglutide and resmetirom usually need to be prescribed by or in consultation with a specialist, such as a gastroenterologist or hepatologist. And we may need to track down some info to confirm that F2 or F3 fibrosis diagnosis. Keep in mind that even though some of these other medications have evidence for MASH, they may not be covered unless the patient is using it for an approved indication. We've also got lots of resources for you. You can print our one-page comparison of drugs for metabolic liver disease to have as a quick reference. And we have many GLP-1 agonist resources as well to help you keep these meds straight. You can use our interactive comparison chart to sort through products, indications, clinical outcomes, and more.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. If you found this episode helpful, follow Clinical Capsules or leave a quick rating or review. It helps others discover the show. Even better, share what you learned with a friend or a colleague and let them know they can find the show on any podcast app or on YouTube. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.